Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about Polycystic Ovarian Syndrome. So what we wanted to discuss today, the definition, the phenotypes, epidemiology, etiology, pathophysiology, diagnosis, and treatment. As you see in this picture, this is a picture by laparoscopy with bilateral polycystic ovary. Both ovaries are enlarged, smooth glistening capsule goes like as you see in this picture. Okay, what about definition of polycystic ovarian syndrome? This is a common endocrine disorder of unknown etiology affecting 5 to 10% of reproductive age women and characterized by ovulatory dysfunction, polycystic ovaries morphology, and hyperandrogenism. Polycystic ovary syndrome is the most common endocrine pathology in female of reproductive age and was described first by Stein and Wenzel in 1935. Okay, what about the phenotypes? Really, according to Rotterdam in 2003, they suggested that if we have 2 out of 3 of the following criteria, we can diagnose PCOS. What is the 3 features? Ovulatory dysfunction, hyperandrogenism, polycystic ovarian morphology by ultrasound. Okay, any 2 out of 3 can diagnose PCOS according to Rotterdam criteria, the old one in 2003 and the recent one in 2020. Okay, so according to this 3 criteria, I can have 4 phenotypes. Phenotype A, including hyperandrogenism of ovulatory dysfunction and the polycystic ovarian morphology by ultrasound. Phenotype B, including hyperandrogenism of ovulatory dysfunction. Phenotype C, carrying the character of hyperandrogenism and the polycystic ovarian morphology. Phenotype D, carrying the features of ovulatory dysfunction and the polycystic ovarian morphology. So, 4 phenotypes can be present according to Rotterdam criteria. But according to Androgen Excess and the PCOS Society in 2006, they make these phenotypes only 3 because they suggested that all cases of PCOS should have hyperandrogenism. So they have only 3 phenotypes. Phenotype A, carrying the character of hyperandrogenism, ovulatory dysfunction, and the polycystic ovarian morphology. Phenotype B, hyperandrogenism and the ovulatory dysfunction. Phenotype C, hyperandrogenism and the polycystic ovarian morphology. So, the consistent difference among PCOS phenotype is the severity of insulin resistance. This is a very important factor, really. The severity of insulin resistance, because most of the pathophysiology around this insulin resistance. It has been well established that National Institutes of Health PCOS phenotype is at higher risk for insulin resistance and associated with metabolic abnormalities compared with non-National Institute Health Rotterdam PCOS phenotypes. What does it mean? National Institute Health divide the phenotypes into 2 categories. Phenotype A and B and the phenotype C and D, that of Rotterdam criteria, okay? And they said phenotype A and B carry higher risk because associated with higher risk insulin resistance and metabolic abnormalities than phenotypes C and D. So they differentiate between them because they are different as regard the risk of insulin resistance and the metabolic abnormalities. So what about ovulatory PCOS? Those who carry hyperandrogenism and polycystic ovarian morphology, but ovulatory. They tend to have lower body mass index than the National Institute Health phenotype, which is category A and B, and they have either mild or no metabolic abnormalities. A recent well-powered meta-analysis of PCOS genome-wide association study has suggested that the current criteria don't identify genetically distinct subgroups, and they need more researches about these genetically distinct subgroups. So what about the epidemiology? I said this is the most common endocrine pathology in female of reproductive age and affecting 5 to 15% of female depending on the diagnostic criteria mentioned before. According to WHO, over 116 million women are affected by PCOS worldwide. In USA, about 5 million women of reproductive age affected by PCOS. PCOS is associated with obesity in 80% of cases and is associated with metabolic syndrome with insulin resistance in 30 to 40% of cases. And this is the most important cases because carry many problems, which can aggravate PCOS. Multiple conditions have been associated with PCOS, including infertility, obesity, metabolic syndrome, impaired glucose tolerance, diabetes mellitus class 2, cardiovascular risk, depression, obstructive sleep apnea, endometrial cancer, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis. So what about the etiology? PCOS is really a multifactorial disease. And up till now, we cannot define the etiology 100%. Okay? But we can say that there is genes responsible for occurrence of PCOS, and this proved in twin studies who estimated about 70% heritability. The second important factor is the environmental factor, and this environmental factor includes the insulin resistance and the obesity. As we will see here in the picture, individual with a genetic predisposition exposed to environmental factors like obesity and insulin resistance, the result will be polycystic ovarian syndrome. Simple like that. What about the pathogenesis and the pathologic effect of insulin resistance and obesity? Go to the left side first. Insulin resistance will cause increased insulin, which affect the liver, leads to decreased steroid hormone binding globulin. That's why the free testosterone will increase. Also, increased insulin will stimulate the ovary to increase androgen production and also stimulate adrenal gland to increase androgen production. So the result will be infertility, menstrual disturbance, and hirsutism. Look to the right side with the effect of insulin resistance and obesity. With the metabolic manifestation, there is glucose intolerance, dyslipidemia, and vascular dysfunction, and on long term will cause vascular disease, like ischemic heart disease and so on. So, Nearly all causes of PCOS are due to functional hyperandrogenism. Two-thirds of PCOS presentation have typical functional ovarian hyperandrogenism, characterized by dysregulation of androgen secretion with an over-response of 17-hydroxyprogesterone to gonadotropin stimulation. The remaining PCOS with the typical functional ovarian hyperandrogenism lack the over-response of 17-hydroxyprogesterone. Functional ovarian hyperandrogenism, PCOS, present with primary features hyperandrogenism, oligoanovulation, polycystic ovary morphology. It is a multifactorial with a combination of hereditable and environmental factor. Causes for this dysregulation include insulin excess, which is known to sensitize the ovary to luteinizing hormone. Androgen excess enhances the initial recruitment of primordial follicle into the growth pool, but simultaneously it initiates premature luteinization, which impairs the selection of the dominant follicle. That's why we identify the growing follicle that reach maturity with PCOS. All of them are small follicle less than 9 millimeter. And this results in the classic PCOS histopathologic and the gross anatomic changes. Ovarian hormonal dysregulation alter the style gonadotropin releasing hormone, potentially leading to relative increase in LH versus FSH by senses and secretion. That's why we found usually the ratio between LH and FSH is 3:1. LH stimulate ovarian androgen production, while the relative decrease of FSH prevent adequate stimulation of aromatase activity within the granulosa cells, decreasing androgen conversion to potent estrogen estradiol. So what about clinical presentation and diagnosis? Clinical presentation, you should take complete history from the patient, including menstrual history, and to know the menstrual pattern, if there is oligomenorrhea or amenorrhea. And we can define the irregular menstruation according to the modified Rotterdam criteria, and as we'll see later on. So complete history taking, history of any drug intake that may cause hirsutism, history of other diseases may give symptoms and signs simulating the PCOS. So from history taking and then examination, and in examination we will see the features of hirsutism with hair distribution in the face, mustache, chin, midline, umbilical region, inner side of the thigh. Okay, so we'll see manifestation of hyperandrogenism. So patients with PCOS usually present with oligomenorrhea or amenorrhea, infertility, hirsutism and acne, obesity and the signs of insulin resistance and hyperinsulinemia, and the impaired glucose tolerance and type 2 diabetes may be. Patients who become pregnant are at increased risk of perinatal complication like gestational diabetes and the preeclampsia. Also, you should know that on long-standing cases, women have an increased risk of endometrial cancer due to unopposed estrogen secretion. Diagnosis of PCOS, depending on modified Rotterdam criteria, depending on 2 out of 3, ovulatory dysfunction, clinical or lab evidence of hyperandrogenism, or polycystic ovarian morphology by ultrasound, as in this picture. This disorder may simulate some features of other disease like thyroid disease, hyperprolactinemia, congenital adrenal hyperplasia, delayed type, and I can differentiate from the delayed type of congenital adrenal hyperplasia by measurement of serum 17-hydroxyprogesterone, which is elevated in delayed type of congenital hyperplasia, adrenal hyperplasia. Okay, but really, diagnosis of PCOS in adolescent is challenging. Why? Because many features of PCOS are common in normal puberty, like acne, menstrual irregularities, hyperinsulinemia. Menstrual irregularities with anovulatory cycles occur due to the immaturity of the hypothalamo-pituitary ovarian axis during the first 2 to 3 years after menarche. So, in these years following menarche, this is usual to see irregular menstruation and the acne and so on. So, persistent oligomenorrhea beyond this period predict ongoing menstrual irregularities and the higher chance of underlying ovarian or adrenal dysfunction. What about the ultrasound rule in this such young age? Is not very helpful really, because they commonly have large multicystic ovaries. So let us go to the first category of Rotterdam criteria. 3 features I said. The first, ovulatory dysfunction and the irregular cycle. In Rotterdam criteria 2020, they said about irregular cycles that this threshold for oligomenorrhea is 35 days cycle in adult, or you can say if it is less than 8 cycles per year, it is oligomenorrhea also, and 45 days in adolescent. And you can consider the irregular cycle is normal in the first year post-menarche as a part of your pubertal transition. After 1 year post-menarche, more than 90 days for any one cycle, of course, suggesting abnormalities. Primary amenorrhea by the age of 15 or more than 3 years post-telarche, which means breast development, is considered also abnormal. Patient with cycles shorter than 35 days can be assessed for ovulation by measurement of mid-luteal serum progesterone or day 21 serum progesterone. What about hyperandrogenism? Clinical hyperandrogenism diagnosed by hirsutism, acne, alopecia. Hair loss pattern are variable, typically in the vertex, crown, or diffuse pattern. In severe hyperandrogenism, the woman may complain from bitemporal hair loss and the loss of the frontal hairline. Adolescent with severe resistant acne to oral and the topical antibiotics may have a 40% likelihood of developing PCOS, and there is high suspicion for hyperandrogenism in females in their mid-20 and to mid-30 with persistent or exacerbated acne. Hirsutism means a coarse, dark, terminal hair distributed in male pattern, including chin, mustache, face, neck, midline, in between the breast, at the umbilical region, inner side of the thigh. What about virilization? Is virilization the same as hirsutism? No, of course no. Virilization is more aggressive one, the more severe one. There is hirsutism, but also there is deep voice, clitoromegaly, decreased size of the breast, and increased muscle mass. And usually this is not symptoms and signs of PCOS. Usually the virilization occurs with adrenal gland secreting androgen, adrenal gland tumors secreting androgen, or adrenal hyperplasia, or ovarian tumor secreting androgen. But PCOS doesn't reach the level of virilization, just hirsutism mostly. So what is the lab test for hyperandrogenism? You test for the free testosterone, free androgen index, or calculated bioavailable testosterone. Should you test another androstenedione and the dihydroepiandrosterone sulfate? Yes, I may ask for them if the free testosterone wasn't elevated. Reliable assessment of hyperandrogenism is not possible in women taking hormonal contraception. So, if you wanna to do lab test for androgen, you should ask the lady to stop hormonal pills for 3 months at least, because the result will not be reliable if she did it while she is taking the contraception pills. If you did the androgen level and you found it markedly elevated, you should search for another cause rather than PCOS, because there may be tumor, as I said, secreting androgen. What about polycystic ovary morphology? This can be done by transvaginal ultrasound with frequency bandwidth 8 megahertz. The resolution is high. I can count the follicle, and according to modified Rotterdam criteria 2020, the follicle per one ovary should exceed 20, and its size measuring between 2 and 9, and the ovarian volume equal to or more than 10 milli. And there must be no corporal lutea, no cyst, and no dominant follicle. What is meant by dominant follicle? Equal to or more than 10 millimeter. This is the modified Rotterdam criteria. What about the old Rotterdam criteria 2003? They said 12 follicles per one ovary, measuring or more, measuring 2 millimeter to 9 millimeter, or ovarian volume equal to or more than 10 millimeter. So there is difference as regards the number of follicles per one ovary and the other criteria as I mentioned. What about anti-Mullerian hormone? Should I test anti-Mullerian hormone in PCOS? You shouldn't do that as an alternative for the detection of polycystic ovarian morphology or as a single test for diagnosis of PCOS. But there is emerging evidence that with improved standardization of assays and established cutoff levels of threshold based on large scale validation in population of different ages and ethnicities, anti-Mullerian hormone assays will be more accurate in detection of PCOM. So we are expecting in the future to be used as an important test. What about ethnic variation in the presentation and the manifestation of PCOS? A relatively mild phenotype in Caucasian, higher body mass index in Caucasian women, especially in North America and Australia, more severe hirsutism in Middle Eastern, Hispanic, and Mediterranean women, increased central adiposity, insulin resistance, diabetes, metabolic risks, and acanthosis nigricans in Southeast Asian and indigenous Australians, higher body mass index and metabolic features in African, lower body mass index and milder hirsutism in East Asians. What about the additional assessment for PCOS? You should know that PCOS represents a higher risk for infertility, obesity, metabolic disorder, impaired glucose tolerance, type 2 diabetes, cardiovascular disease. All of this should be assessed. Women with PCOS have 3 times the increased risk of non-alcoholic fatty liver disease. It has been associated with androgen excess and the low sex hormone binding globulin, an increased risk of endometrial cancer in patients with PCOS. Also, major depression, recurrent depression, suicide attempts were also higher in PCOS women. So, PCOS women should have follow-up long life because they carry problem which can occur early and in long-standing cases. What about post-menopausal phenotype of PCOS? Is there post-menopausal phenotype of PCOS? Yes, really, yes. Post-menopausal persistence of PCOS could be considered likely with continuing evidence of hyperandrogenism. The diagnosis of PCOS post-menopause could be considered if there is a past diagnosis of PCOS, long-term history of irregular menstrual cycle and hyperandrogenism and/or PCOM during the reproductive years. Postmenopausal women presenting with new onset, severe or worsening hyperandrogenism, including hirsutism, require further investigation to rule out androgen secreting tumor and ovarian hyperpsychosis or ovarian tumor secreting androgen or adrenal gland secreting androgen. So this is about the postmenopausal phenotype PCOS. What is the differential diagnosis of PCOS? Late onset congenital adrenal hyperplasia, adrenal tumor, hypothyroidism, use of androgenic steroids, idiopathic or familial hirsutism, ovarian malignancy secreting androgen, like sex cord stromal tumor. Treatment of PCOS include lifestyle modification, which is very important really, in the form of exercise and the calorie restrictive diets with healthy diets, and psychological factors like anxiety and depressive symptoms, body image concern, and disorder eating need consideration to optimize healthy lifestyle engagement. Dietary intervention, generally healthy eating principles, allowing women with PCOS across the life course to achieve weight loss in those with excess weight and energy deficit of 30% could be prescribed for women. Also considering individual energy requirements, body weight, food preferences, and physical activity levels, and an individual approach. Exercise is very important really. Encourage the exercise and advise the following for modest weight loss and prevention of weight gain. A minimum of 250 minutes per week of moderate intensity activity or 150 minutes per week of vigorous intensity or an equivalent combination of both. Also, encourage muscle strengthening activities involving major muscle groups on 2 non-consecutive days per week and minimize sedentary screen or sitting time. The first line treatment include hormonal contraception like COC and the patch or vaginal rings, all of them containing phenylestradiol and progestin. The best is to give the COC with progestin generation, which has an anti-androgenic activity like dysprogesterone and disogestrel. They have direct anti-androgenic property as direct inhibitor of 5-alpha reductase activity to prevent conversion of free testosterone to the more potent form alpha dihydrotestosterone. First line treatment also for menstrual abnormality, hirsutism, acne, all of these get benefit from using COC. The progestin component decrease LH level indirectly, decreasing ovarian androgen production and increasing sex hormone binding globulin. Screening for contraindication for hormonal contraception is important really. You shouldn't give COC in women above the age of 35 and the smoker and associated with uncontrolled hypertension and uncontrolled diabetes with having peripheral vascular disease, completely and absolutely contraindication if she carries all these problems. Oral contraceptive dose of 20 microgram phenylestradiol is better than the higher dose of phenylestradiol. The problem with the progestogen, which has an anti-androgenic activity, is that carry a higher risk of venous thromboembolism. Next is the metformin, which is insulin sensitizer, very important really in treatment of PCOS. Starting patient with diabetes, mellitus type 2, or if there is impaired glucose tolerance, or who fail lifestyle modification. Really, metformin improve the menstrual cycle, improve the abnormal waist to hip ratio, the vascular marker, and the non-obese women with PCOS. Metformin also second-line therapy for menstrual irregularities in patients with a contraindication for hormonal pills. Also, it's commonly used in adolescents as a monotherapy. It helps restore normal menses, weight loss, and reduce insulin resistance. So, it's a really important drug. What about infertility treatment? Clomiphene citrate is the first-line therapy for PCOS patients. Clomiphene citrate is a selective estrogen receptor modulator, competitive inhibitor of estrogen receptor, and has mixed agonist-antagonist activity. As you see in this picture, they block the receptor of estrogen, so they block the negative feedback of estrogen on the hypothalamus. That's why they're releasing GnRH, the pulsatile, which stimulates the pituitary to produce FSH, and so stimulate the growth and the maturation of the follicle. Metformin also is important as an infertility treatment, as an adjuvant treatment, helping in prevention of ovarian hyperstimulation in patients undergoing in vitro fertilization. Letrozole can be used. Letrozole is estrogen modulator, aromatase inhibitor that block estrogen synthesis, reducing the negative estrogenic feedback at the pituitary. So it is used for induction of ovulation with a promising result and successful ovulation. If the previous not effective, you can go forward to the low dose FSH, like recombinant FSH or human menopausal gonadotropin injection for induction of ovulation. But the problem with gonadotropin, it is too costly, and we are afraid also from hyperstimulation syndrome. So we should give it in low dose and very carefully. Then, if not succeed, I can go to the IVF as a third line choice of therapy for infertility with PCOS. Lastly, laparoscopic ovarian drilling for clomiphene-resistant PCOS women can be done, may result in less ovarian hyperstimulation syndrome, but there are risks associated with surgery like anesthesia problems, infection, and adhesions, which may affect fertility also. Some prefer to do unilateral laparoscopic ovarian drilling in spite of bilateral drilling. But you can say laparoscopic ovarian drilling is decreasing these years and the priority for the previous lines of treatment, as I said. Treatment of hyperandrogenism require long-term treatment and takes several months before the effects are evident. Start cosmetic intervention while medication start working. This can be done by bleaching and temporary hair removal methods using galvanic or blended electrolysis for localized areas with experienced operator, using laser photoablation for generalized hirsutism. Pharmacological intervention include topical fluorescein for face, as in this picture, for face hirsutism, which can be an expensive treatment with potentially serious side effects if the body absorbs it. The first line treatment for hirsutism is low-dose neutral or anti-androgenic oral contraceptive, which effectively lower androgen level and effect. Additionally, contraceptive properties are beneficial when combined with anti-androgenic drug because the latter requires reliable contraception as they are highly teratogenic. Mild hirsutism can be treated by oral contraceptive pills alone. Treatment of hyperandrogenism also can be by adjuvant anti-androgen administration for cases considered moderate or severe hirsutism. As this drug have similar efficacy, androgen excess and the PCOS Society suggests prescribing finasteride, cyproterone acetate, or spironolactone instead of glutamide when an anti-androgen is needed due to potential side effects like hepatotoxicity. So, glutamide is associated with hepatotoxicity, so we try to avoid it using cyproterone acetate or spironolactone and so on. Cyproterone acetate, as that present in Diane, with ethinyl estradiol, 21 tablet, 1 tablet per day, and rest for 7 days and repeat next cycle. Spironolactone, as in this picture, 50 milligram or 100 milligram accordingly per day, is the most common adjuvant anti-androgen medication prescribed after COC. It is a non-selective mineralocorticoid receptor antagonist and suppresses testosterone level. Spironolactone has additional benefit regarding the risk of cardiovascular disease compared to oral contraceptive pills. Combination of spironolactone with metformin were superior to monotherapy with either drug regarding improved menstrual cycles, blood glucose during oral glucose tolerance test, and testosterone level. Additional insulin sensitizing treatment, you should know some drugs insulin sensitizing rather than metformin. Now we know metformin very well. Let us see some other drugs. Glucagon-like peptide 1 agonist. This bind to glucagon like peptide 1 receptor and stimulate glucose-dependent insulin release from pancreatic islets. They have a longer half-life than our body's glucagon like peptide 1 because of resistance to degradation by the enzyme DPP4. Data show that GLP-1 secretion was significantly lower in obese compared with lean women with PCOS. And the treatment with GLP-1 agonist was associated with decreased body mass index and testosterone and improved ovulation rate in obese women with PCOS. What else? Additional insulin sensitizing treatment. Dipeptidyl peptidase 4 inhibitors. The abbreviation is DPP4. DPP4 inhibitors, also known as the gliptins, as in this picture, decrease the degradation of insertin. What is insertin? This is gastrointestinal hormone which stimulates production of insulin when it is needed. I mean after eating. Also reduce the production of glucagon by the liver when it is not needed, for example during digestion. And they also slow down digestion and decrease appetite. This is what's called insertins. Okay? Therefore, DPP4 inhibitors increasing glucose-dependent insulin release is usually prescribed for people with type 2 diabetes, and the new data suggests that in obese women with PCOS, DPP4 inhibitors have a beneficial effect in weight loss and the lower blood glucose level. DPP4 inhibitors have been linked with higher rate of pancreatitis, and this is one of the important side effects of this drug. You should know about it. Another insulin sensitizing sodium glucose cotransporter 2 inhibitors. SGL2 SGLT2 inhibitors work like what? Enhance the kidney to excrete glucose in urine, improve weight loss and the cardiovascular risk in patients with type 2 diabetes. In obese patients, there is promising data for weight loss and the fat mass reduction with treatment with SGLT2 inhibitors compared to metformin. FDA approved for use with diet and exercise to lower blood glucose in adults with type 2 diabetes, and there is a higher chance of getting genital and urinary tract infection. This is one of its side effects. Next insulin sensitizing drug, Peroxisome proliferator activated receptor gamma agonist, like glitazone, as in this picture. In PCOS, this drug is used for improvement of hormonal and the metabolic outcome of PCOS cases, but had an adverse effect on weight, increase insulin sensitivity by enhancing storage of fatty acids in fat cells. It can be superior in patients with non-alcoholic fatty liver disease compared to metformin. Lastly, additional insulin sensitizing treatment, myoinositol, as in this picture. This is an over-the-counter food supplement that increases insulin sensitivity. Found in many plants and tissue of animals, food with highest concentration are fruits, beans, corns, and the nuts. Compared with placebo, improved insulin sensitivity in women with PCOS without significant effect on body mass index. Many studies have been performed that show that the treatment with minoxidil plus folic acid in a dose of 2 tablets per day, each one 2000 gram minoxidil plus 200 microgram folic acid per day, leads to significant positive changes of metabolic and hormonal parameters. Its use has been mostly applied as a fertility treatment of PCOS or when metformin is not tolerated, given it has fewer gastrointestinal side effects. But it is still expensive drug also, and also you should know that it is an over-the-counter food supplement, not medically prescribed. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.